There's an unspoken, ugly truth in the beauty industry right now. It isn't that facials don't work, it's that facials don't work for skin of color right now. You walk out of the clinic glowing, the texture feels smooth, yet 6 weeks later, the pigmentation comes back. And often it's darker, deeper, and more stubborn than before. This is called a rebound effect. Most aesthetic practitioners have hearts of gold. They want to help you. However, they're treating you with a curriculum written 40 years ago based on data that excludes the biology of skin of color. Today, I'm going to explain why treatments like hydrofacials, chemical peels, and hydroquinone protocols often fail us in the long run. We're going to look at the endpoint redness myth, the cytotoxicity of bleaching agents, and the specific biology that makes your skin react differently to trauma. Let's talk about the history and data gap when it comes to facials in skin of color. To understand the problem, we have to look at the history. Modern aesthetic dermatology was built on the Fitzpatrick scale, types 1, 2, and 3. Caucasian skin. When we look at clinical studies for facial treatments, less than 20% of historical data specifically isolates skin of color. Most traditional and trending facials are largely tested on Caucasian skin tones. So when a practitioner treats you, they're often using a copy-paste method. They're taught to look for endpoint redness, i.e. erythema. In white skin, turning the skin pink is a sign of a good clinical endpoint. It means controlled injury has occurred. This will stimulate collagen. However, in skin of color, pink does not mean collagen. Pink means inflammation. And in our biology, inflammation leads to PIH, post-inflammatory hyperpigmentation. Let's talk about the specific trending protocols, hydrofacials and Abaji peels. Let's start with physical exfoliation, often marketed as microdermabrasion. This is used in treatments like the hydrofacial. They use physical friction and suction to clean the pores. The intention is good, unclog the skin, but physical scrubs and microdermabrasion create micro tears in the skin. Because skin of color has a more compact epidermis, but fewer fatty ceramides, our barrier is easily disrupted. That suction and friction causes a trauma response. Now, let's talk about hydroquinone. It's often found in systems like Abaji, and honestly, Abaji was revolutionary for its time. It was one of the first professional protocols for hyperpigmentation. However, it was done mainly on Caucasian skin and then exported to the rest of the world. For decades, this was the gold standard for pigmentation. Yet hydroquinone is cytotoxic. It kills the cell, the melanocyte. While it works fast, it can cause a halo hyperpigmentation effect, white rings around the spots. And if used long-term, it causes rebound effect, where the pigmentation comes back aggressively once you stop. Not only does it come back, it tends to come back worse, and it tends to sprout on other parts of the face. It forces the cell into submission rather than regulating it. Next, let's look at deep chemical peels. Standard protocols often use high percentage glycolic acid. These aggressive exfoliations damage the deeper dermal layers. In Caucasian skin, this sheds the damage and you get beautiful results. In skin of color, this heat and trauma wakes up the melanocyte, the cell producing the pigment melanin, and makes it angry. If you want to visualize your melanocyte, the pigment producing cells sitting at the basal layer, think of it like a sleeping guard dog. In skin of color, these melanocytes are larger and more reactive than in Caucasian skin. They are evolutionarily designed to protect you from the sun. When you use high heat, such as lasers or steam, when you use trauma, such as deep microneedling and extractions, or if you use friction, such as scrubs, you're poking that guard dog. The melanocyte wakes up and panics and bites. The bite is melanin overproduction. And here's the trap. It takes weeks for that melanin to travel to the surface. So you look great on day 1, but that pigmentation starts to show up by week 6. This is why aggressive extraction can result in dark marks or even keloid scarring in darker skin tones. So what's the solution? How do we treat hyperpigmentation in darker skin tones without irritating the melanocyte? We work from first principles based on skin of color physiology, and we avoid burns. We move away from cytotoxicity, i.e. killing the cells, and move towards tyrosinase inhibition, regulating the melanocyte. When we engineer a treatment for skin of color, Fitzpatrick 4, 5, and 6, we have to start from first principles. We cannot simply modify existing European protocols because the biology is fundamentally different. Skin of color has a more compact stratum corneum, that top layer of skin, and lower levels of ceramide, and crucially, larger, more reactive melanocytes. Standard facials rely on controlled injury to stimulate repair. However, in melanin-rich skin, injury is rarely controlled. It triggers an inflammatory cascade that leads to pigmentation. Today, I'm going to walk you through through our 5-step corrective protocol we've engineered to bypass this inflammation while still achieving dermal correction. Step 1 is lymphatic cupping. Traditional facials use steam to open pores, but steam causes vasodilation, widening of blood vessels. In skin of color, heat is a primary trigger for inflammation. Therefore, we remove steam entirely. Instead, we use gentle suction cupping to manually drain toxins to the supraclavicular lymph nodes. This helps to depuff and detoxify without adding thermal energy to the system. Step 2, radiofrequency sequencing. We use radiofrequency to stimulate collagen through dermal heating. Unlike lasers, which target chromophores, the pigment, that can accidentally burn darker skin, radiofrequency is colorblind. It bypasses the melanin in the epidermis and delivers heat directly to the dermis to tighten elastin fibers. We use a conductive medium, the glow serum, which is packed with ceramides and peptides to protect the barrier during this heat phase. It's also important that we do radiofrequency first and then later we do microneedling. You never do microneedling first and then radiofrequency simultaneously, because that can lead to hotspots and hyperpigmentation. So even sequencing matters here. Step 3, the glow peel. Most professional peels use glycolic acid because it's cheap and fast. It's a small molecule that penetrates like a bullet. We replace this with mandelic and lactic acid. These are larger molecules that penetrate slowly. However, the innovation here is the inclusion of tyrosinase inhibitors. We formulated this peel with phytic acid, ferulic acid, kojic acid, and ascorbic acid inside the peel itself. This means that at the exact moment we are exfoliating, i.e. removing dead cells, we are simultaneously inhibiting the tyrosinase enzyme. We're chemically sedating the melanocyte so it doesn't panic during the exfoliation process. Step 4, microneedling with the glow serum infusion with a smaller molecular weight. There's a misconception that deeper is better when it comes to microneedling. For acne scarring in white skin, practitioners often go for 1.5 millimeters to 2 millimeters. In skin of color, going deeper than 0.5 millimeters often causes pinpoint bleeding. Most of the time, you'll be fine. However, a small fraction of you during that bleeding process will release something called hemosiderin, which stains the skin and causes deep, stubborn pigmentation. So our protocol strictly caps the depth of microneedling at 0.4 millimeters. This is the precise depth of the dermal-epidermal junction. We create microchannels down to where the melanocyte lives to infuse the glow serum containing tetrahexyldecyl ascorbate and bakuchiol directly to the pigment-producing cells without triggering a wound-healing cascade that can lead to scarring. Step 5, cryotherapy and occlusion with our stem cell glow mask. This step is about cooling and occlusion. After any stimulation, so here we've got radiofrequency and microneedling, we must immediately bring the skin temperature down to prevent inflammation. We apply the glow sheet mask. It's loaded with humectants, anti-inflammatories, tyrosinase inhibitors, stem cells, ceramides, and peptides. We then use a cooling device over the mask. This cryo step constricts blood vessels, i.e. leads to vasoconstriction, which instantly reduces redness, locking in the active ingredients into the barrier. This ensures that the client leaves with the best possible results. This protocol works because it respects the biology of the barrier. There's no steam, which avoids vasodilation. There's large molecular acid, which avoids burns. There's tyrosinase inhibitors, which avoids rebound hyperpigmentation. Microneedling is capped at 0.4 millimeters to avoid bleeding. There's immediate cooling with stem cells to stop inflammation. This is not about pampering. It's about engineering a safe outcome for skin of color that's been historically ignored. If you're a clinic and want to offer this treatment to your patients, write the word yes below and we'll send you the verification link. If you're a patient, however, and want to have access to this treatment, show this video to your favorite clinics and we will do our best to serve them. Here are some of the results and I can't wait to hear your success stories. Now you've finished this, you're gonna love this video.